Hi, I'm Allison Proffitt. I'm the editor of Diagnostics World, and I'm here today with Dr. Glenn Steele, who served as the president of Geisinger Health Systems for 15 years. And last year, you took on the mantle of chairman of XG Health Solutions, which is a company built to share Geisinger's tools and expertise, what they've learned over the past 15 years with other companies. Welcome.
Thank you very much, Allison.
XG Health shares some of the apps, platforms, and solutions that Geisinger built to accelerate and simplify the delivery of care. How important do you think health IT is to changing our healthcare delivery system?
I think it's absolutely critical in order to get behavior change, which is really what it's all about. Whether you're talking about behavior change of providers or whether you're talking about behavior change of patients, there's got to be data fed back almost in real time, and that cannot happen without information technology.
In the fee-for-service and value-based care conversation, I feel like diagnostics gets pushed aside a lot in favor of conversations about treatment and readmissions. How do you think that diagnostics changes in a value-based care model?
I think it's a fundamental change. I think if you're looking at units of work and you're trying to figure out what your profit margin is for each unit of work, you have a completely different calculus, and you have a different buy decision maker compared to if you're looking at value over time for a patient, regardless of whether they're being treated in the hospital or out of the hospital, what have you. So it's a fundamental change in the business model for the diagnostics, absolutely.
So a couple of years ago at Geisinger, you were offering some capitated services, and you said then that the insurers were not very enthusiastic about the plan. How have you found that to change over the past 18 months?
Well, this has to do more with my perspective on national as opposed to just the Geisinger market. But there's no question that if you look at the public payer, what the public payer is doing in Medicare or the public payer in Medicaid, there's much more of a shared risk with the providers. And what that means is that for the non-public payer, I'm talking about the commercial HMOs, the commercial PPOs, they don't want to be the contributor to the revenue that's taken away by the expanding public payer. So even for the commercial market, there is much more of a shared risk between payer and provider. Much more of it's capitation. It's called something else, but it's essentially shared risk for patient's outcome over time. So it's happening across the entire country.
Treatment in the emergency department is much more expensive for the patient, for the healthcare provider, for the system. How can we encourage people to move away from the emergency department?
Well, first of all, when a patient who's got a significant problem is discharged from the acute care facility, we can do a lot of basic blocking and tackling stuff to decrease the probabilities that they end up bouncing back in a week or 2 weeks. Secondly, there's an awful lot of non-severe illness that get people to default back to the emergency room. And a huge amount of that can be dealt with in urgent care centers, in doctors' offices, in ways that are more efficient for the patient as well as, incredibly less costly. And that's happening both within integrated structures like Geisinger, but it's also happening in markets that are, much less integrated, no question.
How important are large-scale efforts toward encouraging healthy habits and lifestyle choices across the population?
They're extraordinarily important, and in general, what you want to do is activate human beings, whether they're patients or before they get a disease. You want to get them much more actively involved in responsibility for their own outcome. Most of the time for prevention, particularly early on in a person's life, it's inconceivable to them that they'll ever get sick. And so the return on investment and the ability to get people engaged has been the problem. Where you can start with a relatively obvious return on investment over a short period of time is in patients that or people that already have chronic diseases, whether it's diabetes or whether it's hypertension or what have you. There are very good ways of doing what's called secondary prevention that have been shown in a relatively short period of time for type 2 diabetes within 2 to 3 years to fundamentally change the probability of them getting heart attack, stroke, eyeball disease, or kidney disease related to diabetes. So that secondary prevention is really relatively obvious return on investment for a short period of time.
Dr. Steele, you are about to give the keynote here at the Next Generation Diagnostics Summit in about 20 minutes. Can you give me a little preview of what you're going to share?
I'm going to say that for almost every aspect of the healthcare food chain, the move from fee-for-service to payment for better outcome over time is going to challenge the business models. It's going to challenge the business models of pharma, challenge the business models of providers, payers, and for device manufacturers. And that includes who you're selling to, how the buy decision is made. It's going to be much less focused on price per unit of work, and it's going to be much more focused on what's the value that my particular device or my particular technology brings over a period of time for a patient or a patient cohort. That's the key.
Dr. Steele, thank you so much. We're thrilled to have you at the Next Generation Diagnostics Summit.